Good morning. I'm Professor Iannetti. I come from Rome University La Sapienza, and I'm happy to be here at the International Conference on the Gastroenterology, Digestive and Disorders. I thank you, all the conference organizer, moderators and co-moderators, speaker of this session, and the whole audience. My topic will be clinical management of gastroesophageal reflux disease and endoscopic therapy, an update of the latest techniques, and a review of literature on the subject. Now, as everyone knows, these are the clinical presentation of gastroenteric or gastroesophageal reflux disease. We can have dysphagia, cough, rhinitis, burning mouth, chest pain that mimic a heart attack. So the best definition, in my view, is that GERD is a condition that develops when the reflux of stomach contents in esophagus causes troublesome symptoms and or complication. So my colleagues, internists and physiopathologists can explain how to define the type of gastric reflux and try to combat the disease with dietary, behavioral, pharmacological and also physiotherapeutic methods. My colleagues surgeons have the possibility of performing a laparoscopic fundoplication. There are some therapeutic novelties as the magnetic collar, and I will talk later about this. And now let's talk about the symptoms. As you know, the symptoms of a gastroesophageal and gastroesophageal reflux. The symptoms of gastroesophageal and gastropharyngeal reflux are common and other symptoms. The most common symptoms are heartburn, regurgitation, and dysphagia. Extraesophageal manifestation may be bronchospasm, laryngitis, and chronic cough. Other symptoms include chest pain, globus sensation, dinophagia, postnasal drip, sinusitis, dysphonia, headache. And diagnosis can be based upon clinical symptoms alone, but it's preferable to make at least a gastroscopy and also an upper abdominal ultrasound. Response to anti-secretory therapy, I remember, is not a diagnostic criterion for GERD. For most patients, diagnostic test is required to confirm the diagnosis of GERD, assess for complication, and rule out other diagnoses. And it's important also make a differential diagnosis. The other diagnoses may be infectious esophagitis, pill esophagitis, eosinophilic esophagitis, peptic ulcer disease, non-ulcer dyspepsia, coronary artery disease, esophageal motor disorders. And upper gastrointestinal endoscopy may be not required in the presence of typical GERD symptoms, as some people say in the study in American Journal of Gastroenterology of 2013. But I think that upper endoscopy provides a mechanism for detecting, stratifying, and managing the esophageal manifestation. So, indication for upper gastrointestinal endoscopy are to rule out complication when you have alert features like dysphagia or dinophagia, gastrointestinal bleeding of the cause, anemia, weight loss, and recurrent vomiting. Severe erosive esophagitis, LA classification grade C, on initial endoscopy, so you need follow-up endoscopy after a 2-month course of PPI therapy. And other indication for upper gastrointestinal endoscopy are men older than 50 years and with additional risk factors for Barrett's esophagus, nocturnal reflux symptoms, hiatal hernia, elevated BMI, and if symptoms persist despite the therapeutic trials of 4 to 8 weeks. And another important diagnostic method is the pH monitoring. The gold standard. This is the gold standard for diagnosing, quantifying acid reflux and correlate, and especially correlate symptoms to reflux. And you have to connect it to a data recorder, so you will have data gain from the study and exactly total number of reflux episodes, longest episodes of reflux, number of episodes longer than 5 minutes, extent to reflux in upright position and supine position, and correspondence, especially correspondence between symptoms and reflux episodes. But another device, very important, is the multi-channel intraluminal impedance devices. We have a catheter-based method to detect intraluminal bolus movement within the esophagus. The MII is performed in combination with manometry or pH testing. When combined with manometry, it provides information on the functional component of manometrically detected contraction. When combined with pH testing, it allows for detection of gastroesophageal reflux independent of pH. The esophageal pH impedance, MII-pH, is today considered the gold standard to objectify the gastroesophageal reflux, as it allows to recognize any episode and to define the composition, duration, location, and pH of refluxes. So, indication for pH impedance are for study patient endoscopically controlled and with symptoms resistant to therapy, patient with atypical symptoms such as chest pain or exoesophageal symptoms, and patient in which it is placed indication to surgical procedures. Esophageal manometry is primarily done to rule out motility disorders which may mimic symptoms of reflux. It allows the surgeon to plan for the best operative procedure, and it is a typical picture of the manometric study. Manometric findings, just to remember, normal pressure at lower esophageal sphincter range from 12 to 30 millimeters of mercury. Sphincter generally relaxes to the pressure of the gastric basiline for several seconds when a swallowing is initiated. An effective esophageal motility is defined as less than 70% peristalsis, and distal esophageal amplitudes less than 30 mm of mercury is associated with significant GERD. And now go a brief remember of medical management. Treatment of gastroesophageal reflux disease involves a stepwise approach. The goals are to control symptoms, to heal esophagitis, so the mucosa, and prevent recurrent esophagitis or other complications. The treatment is based on lifestyle modification, control of gastric acid secretion, and so therapy with antacid or PPIs or cimetidine, and control alkaline reflux and enteric motility or surgical treatment. And approximately 80% of patients have a recurrent but non-progressive form of GERD that is controlled with medical therapy. Identifying the 20% of patients who have a progressive form of the disease is important because they may develop severe complications, and so they have to go to surgical procedure at an early stage before to have complications. And other considerations are that the use of patient management tools such as the self-administered GERD questionnaire to stratify patients may improve the management of GERD patients, and in the case of long-term treatment with PPI, the potential adverse events caused by continued use should be considered. And we have two types of medical therapy, the step-up and the step-down. The step-up is an approach providing the advantage of minimum usage of PPIs. Step-down approach provides faster symptom relief. So the step-up therapy is indicated for GERD patients with mild or intermittent symptoms, fewer than 2 episodes per week, who have no evidence of erosive esophagitis on upper endoscopy. So the step up provide the first step is the weight loss, so lifestyle modification, weight loss, elevation of head and in the bed with nocturnal on the laryngeal symptoms, refraining from assuming a supine position after meals, avoidance of meals 2 to 3 hours before bedtime. And lifestyle modification are dietary modification, elimination of dietary triggers, avoid sweets, mint, chewing gum, tobacco, alcohol, etc. And the further step is the antacid absorption, such as magnesium trisilicate, and that neutralizes gastric pH and gives relief of heartburn within 5 minutes, but that has a short duration of effect. And the H2 receptor antagonists decrease the secretion of acid by inhibiting the histamine 2 receptor on the gastric parietal cell. It has a slower onset of action, around 2-3 hours, but significantly longer duration, to 4 to 10 hours. But you can have tachyphylaxis. And PPI, proton pump inhibitors, gives irreversibly binds and inhibits the HK ATPase pump. Should be administered daily rather than on demand, and the standard dose is for 8 weeks to relieve symptoms of GERD and heal esophagitis. But very often you have recurrent symptoms in GERD disease, and 2/3 of patients with non-erosive reflux disease and all patients with erosive esophagitis relapse when acid suppression is discontinued. If recurrence after 3 months of discontinuation, you have to repeat 8-week course of acid suppressive therapy, but if recurrence happens less than 3 months of discontinuation, another upper gastrointestinal endoscopy should be performed to rule out complication, and you have to give this patient long-term acid suppressive therapy. And this is a study about potential adverse effects of PPI inhibitors. The review summarizes potential adverse effects of proton pump inhibitors, PPIs, including nutritional deficiency, like vitamin, rebound acid hypersecretion when discontinued, acute interstitial nephritis, gastric carcinoid tumor, cardiovascular risk, bone fracture, enteric infections, and pneumonia. But recent findings show that the evidence for PPI adverse events is limited by the absence of level 1 studies. The best evidence support Clostridium difficile and bone fractures in susceptible population. A substantial reduction in gastrointestinal bleeding risk without increase in cardiovascular events was observed in the COGENT trial. So the risk of the pneumonia is inconsistent, and although acute interstitial nephritis, nutritional deficiencies, and gastric carcinoid and rebound hyperacidity when are biologically plausible, studies have failed to demonstrate supportive clinical relevance. So the summary of the study is that prescribe PPI for robust indication only, and strong data support risk of adverse events are lacking. However, exercise caution in the elderly and in patients with other risk factors. And now come to surgical management. Indication for surgery is when failed optimal medical management, when there is no compliance, high volume reflux, severe esophagitis by endoscopy, benign stricture, Barrett's columnar lined epithelium without severe dysplasia, and young age and patient choice considering the adverse event of chronic therapy. And this is a flow chart where you can see the new paradigm is that when you have a refractory GERD patient, if he has a small hiatal hernia, adequate less pressure, no extraesophageal symptoms, and non-Barrett esophagus, he can do 2 endoscopic surgery, but if he has a large hiatal hernia, no less pressure, asthma, or recurrent pneumonia in Barrett's esophagus, it's better to go to laparoscopic procedure. But really, I do not agree very much about the exclusion from the endoscopic treatment of extra esophageal symptoms, and then later we'll see why. Principles of surgery are restoration of intra-abdominal portion of esophagus to maintain a pressure differential between thoracic and abdominal esophagus. Creation of a loose wrap around the gastroesophageal junction to restore the medical effect, the mechanical effect of it, so the fundoplication, and reduction of any hiatus hernia and approximation of the crural fibers to narrow the hiatus. And we have many surgical techniques, but the most common of this is the Nissen procedure. The Nissen fundoplication is called gastric fundoplication. It is a full, so 360 degree posterior wrap around the lower esophagus, and it can be performed by standard laparoscopic technique, and today the fundoplication is almost exclusively performed laparoscopically. And the spread of laparoscopic surgery has partially changed the attitude and the direction of the reflux surgery. Currently, some guidelines suggest that laparoscopic surgical procedure is good for patients who respond discreetly to medical therapy but have severe relapses after withdrawal of the same, and that they are young and not want to undergo a continuous medical treatment. And this is the port placement for the laparoscopic procedure. This is the technique. You see the division of the gastrohepatic ligament and also all the other technique you can see in these pictures. The Schoenstein maneuver to realize the wrap for the fundoplication, and this creation of a 2 centimeter wrap, and we see in this picture the types of fundoplication failure, because we can have also some failure. And we have also partial fundoplication that are Toupet and Dor procedure. It's not application of a 30-60 degree, but of 270 or 180. This is the Toupet fundoplication, some picture about it, and the Dor technique. And in the laparoscopic procedure, we can have also complications that can be intraoperative, early postoperative, and delayed postoperative. Intraoperative complication can be access injuries, dissection injuries, and bleeding complications. Early postoperative complication can be delayed perforation of stomach, esophagus, deep vein thrombosis, dysphagia. And delayed postoperative complication can be dysphagia, gas bloat recurrence of the reflux because RAP herniation, RAP disruption, or diarrhea for vagal injury. And now I talk about a new surgical procedure, always laparoscopic procedure, that is called LINX system. The device is called LINX Reflux Management System and consists of a series of titanium spheres with a magnetic core inside. This magnetic collar, as it's called, aims to strengthen the anti-reflux of the lower esophageal sphincter efficacy, and it is implanted with standard laparoscopic procedure. The strength that the magnetic cores apply on each other increase the ability of the sphincter to resist opening pressure from below, from the gastric cavity. These magnetic bonds are instead broken easily upon arrival of the food bolus from above, that is originating from the esophagus, which has greater propulsive force due to peristalsis and the force of gravity. And this is the picture of the device. This is the schematic picture of the implant of the LINX collar. And now I talk about another laparoscopic procedure. It's called endosteam. The endosteam is another always surgical procedure which does not at all alter the anatomy of the esophagus gastric sphincter. The surgical procedure only serves to implant electrodes in the distal esophagus. The method is named from the implantable pulse generator, which is called endosteam, a stimulator that sends electric impulses to the lower esophageal sphincter through two electrodes. The device, which has a lithium battery, is placed under the skin of the abdomen. The electrodes are implanted in the seromuscular layer of the cardia, and the surgery is served to implant the electrodes and the stimulator, and lasts about 45 minutes and is performed under general anesthesia. The indication is for patients with gastroesophageal reflux disease of mild degree in the absence of cardiac arrhythmias, because the pulse generator can give some problem to the heart rhythms. And this is the picture, schematic picture of the implant of the device endosteam. And now come to endoscopic therapy. And now we talk about endoluminal therapies. There are some different kind of techniques. The radiofrequency, the mucosal resection, injection of implantation techniques, and endoscopic application suturing. So let's talk about the radiofrequency stretta. I have to say that the greater radiofrequency application is currently focused on the treatment of Barrett's esophagus. The principle is a radiofrequency energy delivery, and the key equipment is a RF radiofrequency control module and flexible stretta catheter. And this is the picture of the procedure. And this method can be performed with the device in the passage of the endoscope channel, or, much more frequently, inserting it later under radiological guidance after taking the measures during gastroscopy. The procedure is a minimally invasive method, and the action takes place in two stages. A gastroscopy is performed to measure the patient's esophagus, is subsequently orally placing a catheter until the lower esophageal sphincter previously located. In this point, you dilate the bellum catheter, from which they protrude 4 needles, with which the radiofrequency is applied. This procedure is performed under general anesthesia, as you need the patient's immobility. The heat should make the lower esophageal sphincter more toned and resistant, and certainly it compromises the sensory receptor of the esophagus, so you get the reduction of the pain sensitivity. And this is the flowchart of the procedure. You see RF energy delivery, which makes shrinkage of esophageal collagen fibers, remodels the stretch fibers in the cardia, tightens the lower esophageal sphincter, and you obtain the interruption of vagal afferent signals to brain system. And in this way, you prevent gastric reflux and reduce transient lower esophageal sphincter relaxations. Another technique is the mucosal resection, and is an anti-reflux mucosectomy. The name is endoscopic. EARMS means endoscopic anti-reflux mucosectomy. It's based on the principle that after mucosal resection, mucosal healing causes scar formation. This results in retraction and remodeling of the esophagus gastric junction, similar to the Stretta procedure. This reduces the reflux episodes. The fifth case was executed more than 10 years ago, but the results of the first series were published recently. So you have to perform a resection, half-moon resection of esophageal mucosa. It's not possible to perform a circumferential resection to prevent stenosis. And this is the picture of the procedure. You see, you perform this mucosectomy, and after some months in the B picture, you see the appearance after 3 years, a tight gastroesophageal junction, and also more than 10 years later, and you see that the chromoendoscopy demonstrates well-stained squamous epithelium with neither recurrence of esophagitis nor Barrett. And this is another series of pictures. So, the procedure is emerging as a minimal invasive treatment option, but long-term follow-up data with durable response tests are available for the radiofrequency method and for transoral fundoplication technique like MUSE, not yet for ERMS. But some drawbacks with ERMS are remarkable. First of all, these devices were tested in selected patients with minimal esophageal inflammation. Second, although the symptom response is good, objective data, such as the EAET, exposure time of esophageal to acid, is less evident. And the need of PPI use is reduced, but not completely eliminated. And last, long-term data with some recently introduced EAR are not sufficient, and there are no comparative studies. The injection techniques are a little bit obsolete, or in Western countries are no more performed. You have the Gatekeeper, Plexigas, and the Enterix procedure. Allora, so the Gatekeeper is a reflex repair system, utilizes a soft, pliable, expandable prosthesis made of a polyacrylonitrile-based HIPAN. And this process is implanted into the esophageal mucosa, submucosa, and the process absorbs water and expands itself, creating bulk in the region of implantation. This study about this Gatekeeper reflex repair system was performed by Paul Fawkes in 2010, and The investigators concluded that the gatekeeper procedure was associated with some serious but infrequent complications, but no statistically significant difference in outcomes were observed between the treatment and control groups. This is the picture of the gatekeeper reflex repair system. The Plexigas and DuraSphere are two procedures of injection, also these are injection procedures, which involves injection of an inert polymer material into the submucosa of the proximal lower esophageal sphincter zone to provide bulking support to the sphincter and decrease transfer relaxation. It is a suspension of polymethyl methacrylate microspheres in gelatin solution. Gelatin is phagocytosed by macrophages within 3 months and is replaced by fibroblasts and collagen fibers. DuraSphere is a very similar procedure. And the Enterix procedure was a very good, very efficient procedure, but in 2005, the Food and Drug Administration ordered the immediate suspension of Enterix as severe adverse reaction, in particular embolization, were reported. And this is the picture, the schematic picture of the Enterix system. And come now to the endoscopic application suturing. That is the most important for me. It's the most important and physiological procedure, as they are very similar to the laparoscopic surgical procedure. And there are four principal techniques: the Esofix, Endochinch, Muse, and Gerdix. All of these are called transoral incisionless fundoplication, are so endoscopic procedure because they are incisionless, so they go through the mouth, and they perform a fundoplication of the stomach to the cardiac level by a gastroscopy. The device creates a full thickness fold from serosa to serosa and strengthens the sphincter esophageal gastric. These procedures are less invasive alternatives of laparoscopy. The Esofix device for this TIF method, TIF means transoral incisionless fundoplication, is manufactured by endogastric solution and allows the creation of fundoplication, esophagogastric, of 2 or 3 centimeters for circumferential extension of 270 degrees, capturing the mucosa tissue with 12 or more points of polypropylene suture. The device is used in combination with an endoscope flexible video, which provides the endoscopic visualization throughout the operation. And the Esofix proceeding showed, as many authoritative scientific journals have published, a good symptoms control, but for a short time, because the intervention does not allow by endoscopy the immobilization of the gastric fundus, and the tension of the stitches causes, in the long run, their failure and the return to the status quo ante. And it is known, moreover, that even surgical procedure, laparoscopic procedure, in many cases are burdened by recurrences after some years, but sometimes also after a few months. This is the Esofix technique. You see the device in the stomach, which capture the mucosa, fold, and perform a fundoplication. And this is the picture of the procedure. And this endoluminal fundoplication, this ELF procedure, can be tailored to the individual patient and his particular anatomy. The post-intervention histological examination confirmed that ESOFIX creates a valve which incorporates the muscular wall of the fundus of the stomach, made more solid by the development of collagen between the two layers of the fold. The phrenicoesophageal ligaments are incorporated within the valve, stabilizing and increasing their holding, anchoring it to the diaphragm. ESOFIX reduces adverse events, frequent, of course, much more frequent in surgical approach, such as dysphagia, pain, and longer recovery times. The long-term studies, however, show that very often there are failure of the stitches because of the reason that I told before. So, in the long run, the esophageal junction becomes again pathological. And this is a review of endoluminal treatment for gastroesophageal reflux disease by the Board of Governors of the Society of American Gastrointestinal Endoscopic Surgeons. And they say that laparoscopic fundoplication remains the gold standard intervention for GERD in both adults and children. Multiple studies document that the long-term success of laparoscopic fundoplication is very good. But notwithstanding the success of surgical fundoplication, patients and providers continue to search for increasingly less invasive approaches to GERD, especially emphasizing techniques that seek to reduce the risk of dysphagia, bloating, and adverse outcomes sometimes associated with surgery. The review considered two procedures based on endoscopic platform, ESOFIX and Stretta, that provide alternatives to the pharmacologic and surgical treatment for GERD. In considering the clinical application of these and other alternatives to the effective therapy provided by laparoscopic fundoplication for patients for GERD, the reader is asked to consider the degree of symptom relief and the restoration of physiologic function. Some endoluminal therapy may not offer the same degree of relief provided by surgery, but may still represent viable alternatives for patients seeking relief from lifelong dependence on pharmacologic therapy, its cost-associated side effects, and long-term adverse outcomes. So, the ESOFIX device has been studied across a broad range of adult patient population and reported in one adolescent study. Results appear mixed, in some series reporting disappointing outcomes and other reporting promising short-term results. But for all of these studies, we have the result that long-term data are not available in the near future, will most likely be based upon the fifth generation devices. But the creation of the ESOFIX database and registry will aid in future, represent important to making more meaningful recommendation with respect to placement of transoral incisional fundoplication in the treatment of patients with GERD. That means that going ahead, the devices are going to be much more compliant, much more effective. So, in any case, you see that the recommendation for ESOFIX has a low quality of evidence and a weak grade of recommendation. But for Stretta, it is different because the conclusion of this review about Stretta tells that more than 30 review studies, including 4 adequately powered randomized control studies, have documented the safety and efficacy of the Stretta procedure. Durable treatment outcomes at least to 48 months also have been demonstrated in multiple studies with significant reduction of or elimination of medication used to treat the symptoms of GERD, as well as improvement in GERD quality of life. Stretta may be recommended as an appropriate therapeutic option. And you see that the recommendation for Stretta procedure has a very good quality of evidence and a strong grade of recommendation. The Bard Endochinch is another procedure which with another devices very similar to ESOFIX, but this device has a particular nick. It is at the top of the endoscope, in which the mucosa is catched, and in this way it reduces the cardiac space as happens in the surgical intervention, creating these mucosal folds below the lower esophageal sphincter, with the sutures carried through the gastroscope. This method, like all endoscopic procedures, is burdened by the loss of long-term efficacy. And so the presence of this nick at the end part of the endoscope, where it is sucked the mucosa of the esophageal junction before applying the stitches, had made hope for a better grip of the same as compared to other endolaminar procedures. But the clinical evidence does not support this point of view. So also in this case, for Bard Endochinch devices, we have good effectiveness in short time follow-up, but sutures were significantly lost within the 6-month follow-up period. And you see the picture of the Bard Endochinch procedure with the nick I told you before. And this is another picture. So this is a study on the Endochinch in which the conclusion is the Endochinch procedure is a safe and minimally invasive endoscopic treatment for GERD with reasonable short-term results. In contrast, long-term outcome is disappointing. And now go to the MUSE, Medicus Ultrasonic Surgical Endostapler. This method is a TIF, transoral incisionless fundoplication, and in this case the MUSE offer the advantage of a single tool equipped with a stapler, easily radiation, in which the presence of a mini ultrasound on the tip of the endoscope, of the special endoscope, allows the identification of the exact point where the thickness of the lining of the esophageal gastric junction is increased, allowing to capture greater thickness of the mucous layer safely operating. In other words, the operator runs a smaller risk of transmural mediastinal drilling because he assesses with a mini ultrasound the wall thickness and he captures more tissue, making it more stable than stitches too. And this is the picture. You see the ultrasound device on the top of the tip of the endoscope, and I have to see that the procedure is also automatic. So the operation by the surgeon is very, very limited. The safety and efficacy of endoscopic therapy. This is a summary over all endoscopic application suturing. The safety of and efficacy of endoscopic therapies for the treatment of GERD have not been established in the published medical literature. This is a policy number of surgery. And current studies are too small or moderate size, lack adequate control or comparison group, and provide only short-term follow-up. And now go to the last method, the GERD-X. GERD-X is a novel, new device which is very similar to the previous applicator of NDO Surge. The novelty is that the stitches applied by GERD-X, filed for the stapler, have at their ends two plates of polytetrafluoroethylene, PTFE, which reinforce the suture and make it resistant to fracture. These platelets, formed of the same material that is used in surgery to pack the wire mesh for hernia protection, cement subsequently with the tissue, making it more stable application. Study underway and those already performed with the previous applicator that I told you before, the EndoSurge applicator, demonstrates a greater hold over time of endoscopic application with platelets, which has been compared to surgical procedure of fund application. This new GERD-X tool is disposable and allows the passage within it of a thin gastroscope of service for visual control. The operator is facilitated by the good maneuverability and by the microhydraulic technology of the device. This is the tip of the device. You see there is a retractor of mucosa which serves to capture the appropriate amount of tissue. And after the technique of suck and shut, which brings the mucosa inside of the valves, where the points are preassembled and are shut. And this is another picture. You see the same devices with the retractor, and under visual control of the gastroscope camera, the operator applies the sutures described, operating twice or three times, not more, in succession, according to the time of the method. And this is the retractor of mucosa, which captures the appropriate amount of tissue, and the platelet. Some words about clinical studies to which I refer show a minimal complication rate and only 0.3% of complication, a bleeding complication. The not occurred organ perforation, post-procedural stenosis. This advantage of the endoluminal endoscopic procedures compared to surgery are the reduction of operative complication, perforation, bleeding, post-procedural stenosis, and the reduced period of hospitalization, the simplicity of the intervention, with the possibility, this is very important, of repeating it or of switching to surgery in case of ineffectiveness. And this is a study of multiple implants with an NDO applicator. The NDO applicator is the precursor of the GERD-X. And in this study, the authors conclude that the possibility of multiple, more than two or more, at least two transmural sutures provide with platelets and are much more better results. And so the conclusion is the endoscopic full thickness application using multiple applicator implants can be used safely and effectively to improve GERD symptoms. They are considered all patients, even those who have abandoned the experiment, and not only who have completed the study. This is the intention to treat analysis. And there are good results. And another study is comparative between endoscopic and laparoscopic application. This is a study in which the results talk about that endoscopic application and laparoscopic for the application resulted in significant symptoms improvement with similar quality of life scores in a selected patient population with GERS, whereas operative treatment, so laparoscopic treatment, was more effective in the relief of heartburn and regurgitation at the expense of higher short-term dysphagia rates. And this is the picture of the device. And another study about, this is a very good study. As I told you before, there are conflictual results in some studies. In some studies, there are very good results, like in this study, in which the results talk that the effectiveness of the procedure remain after 60 months, so after 10 years, after 5 years. And as you see, the conclusion of these studies is that endoscopic full thickness application performed by NDO applicator, the precursor of the GERD-X, reduce symptoms and medication use for at least 5 years. And this is the only study which talk about a very long period. And this is the microhydraulic system. And this is another study about full thickness applicator and the results measured by manometry and multi-channel intraluminal impedance testing after 1 year, because they say that subjective and especially objective data after endoluminal full thickness application are scarce. So, to evaluate the symptoms and the reflux activity 12 months after gastroapplication by using a pH measure and also manometry. And we see that the main outcome measurement show that the MR scores decreases in a significant way, and manometric data were virtually unchanged. So the conclusion is that endoscopic application is safe and improves objective and also objective parameters at 1 year follow-up. And this is the picture of the steps of the GERD procedure. Gather tissue, you see, the place of implant and the reopen arm. And another study, this is about all endoscopic procedure, is published on a British Journal of Surgery, is performed by Chen and Ali, is conducted by a systematic review that included 33 studies examining 7 endoscopic procedures. At only 3 procedures were compared with sham controls: Stretta procedure, Bard Endochinch, and Enterix. Enterix, as you know, was abandoned by because FDA said that it's not a quiet, sure, a safe procedure. And they see, however, for the two procedures, so that is Stretta and Bard Endocinch, outcomes for patients in the endoscopic groups were conflicting. Some patients in the endoscopic groups experienced comparable outcomes as patients undergoing to the laparoscopic approach, while other studies experienced inferior outcomes. So, the authors of this review, of this systematic review of 33 studies, concluded that there is insufficient evidence for determining the safety and efficacy of endoscopic procedure. So, I think that the take-home message can be that in most cases, the medical management of gastroesophageal reflux disease is preferable and much more well accepted by the patients. In non-responders, in cases where PPI therapy is problematic and in cases where the young age of the patient is unaware of the chronic use of drugs, the indication for surgical therapy is appropriate. Laparoscopic fundoplication offers greater guarantees of long-term success at the expense of greater operation risk and a failure to repeat the procedure in a short time. Stretta and Herms methods fibroids and the esophageal mucosa with good probability of resolution even in the long run. Injecting and implanting techniques presented problems of adverse events and are not effective in long term. The endoscopic procedure of fundoplication are Muse, Gerdix, Esofix, Endocinch, although partially less effective than laparoscopic fundoplication. I think that find its space as appropriate physiopathologically remedy, if only as a bridge to laparoscopic surgery. Thank you for your attention.